All right, you're seeing the correct view.
Yes,
Great.
thank you.
All right. Well, thank you all for joining. I'm very excited to be part of this group. As was mentioned before, my name is Emma Bainbridge. I'm an infectious disease doctor in San Francisco. I provide HIV primary care, and I also do ID consultation. I'm working with my colleague, Dr. Szymowski. I will go through the slides here, but he may be giving some input throughout the way. If questions come up, please go ahead and put them in the chat. I'm not going to be able to see them while I'm presenting, but we'll have a number of stopping points for discussion and some polls as well. We want this to be an interactive experience, and so as questions arise, we're happy to answer them for you all. All right. So here I just have a table format of the case that we just went through. It's a complicated and rich case. I think a lot of opportunities for learning, and we'll use this as an introduction to HIV resistance and assessing genotypes. So just to summarize what we just went through, this patient initially was diagnosed in 2018 with a CD4 count of 65 and was started on a regimen of lamivudine, tenofovir, and efavirenz, and did achieve undetectable status with that regimen, but unfortunately was lost to follow-up for a period of about a year. And then he was restarted on therapy, but did not have his viral load a month after restarting therapy was still 89,000, and he had a genotype which showed the following mutations, and we're going to go into these in depth. And that was when his ART was switched. So I'll just stop there and we can move on to some questions, and we'll go stepwise through the case. So I have two audience polls based on this genotype. I'm going to go through the two questions, and then we'll pull up the poll for you all to respond. The case patient's genotype had the following mutations: a K65R, M184I, K101E, Y181C, G190A, and K103N. The first question is a true-false question. I feel confident interpreting this patient's genotype. And then the second one is, I feel confident selecting an appropriate second-line ART regimen. So if we could pull up the poll now, that would be great. And I'll give you about 30 seconds to answer, maybe less if we get a lot of responses.
Vicky, you can share the poll questions.
They've been shared.
Thank you.
All right, 5 more seconds here. Okay, so I'll end the poll, and I'm going to share the results. So it looks like about 3/4 of the group do not feel confident interpreting the genotype, and 3/4 of the group do not feel confident selecting an appropriate second-line regimen. And that's great, because that's what we're going to walk through today. And I think this is it's really helpful to hear your responses, just because that gives us a sense of what would be useful information for us to share in our future lectures. So I'll stop sharing the poll and we'll move on with the talk here. All right, so just briefly going through some learning objectives, we are going to review the basics of HIV resistance and introduce and use the Stanford HIV drug resistance database. And then we'll list common NRTI and NNRTI mutations, and we'll interpret the genotype from our case and analyze the impact of the mutations on first and second line ART regimens that you all are using in the Philippines. So getting to the basics of HIV resistance, really just dwelling it down to the core concepts here. In uncontrolled HIV, when patients are not receiving appropriate ART, errors occur during reverse transcriptase, and these errors occur at very high rates, and they introduce mutations into the HIV DNA that is being created in human cells. And there's so much replication that's happening. HIV is not able to go back and excise those incorrect nucleotides. And so those mutations end up staying in the code. And they lead to amino acid substitutions in the proteins that HIV makes. So, or rather, HIV makes with our own machinery. So the HIV reverse transcriptase enzyme, protease, and integrase enzymes are all affected by mutations. And those, of course, are our targets for our antiretroviral drugs. So when we see these mutations, the effectiveness of our drugs may be reduced. And when you have a situation where a patient has poor adherence, the HIV strains with resistance mutations become the dominant strains in the infection. And with poor adherence, you may continue to accumulate more and more mutations that make your antiretroviral therapy less effective. I want to talk briefly about the notation for HIV mutations, so it's clear what we're talking about. So here on the right bottom of the slide, I have a common mutation you may see in M184V. This is a mutation that occurs in the reverse transcriptase gene. The M refers to an amino acid, methionine, that's part of the peptide chain that makes up the reverse transcriptase. And the 184 is the amino acid or the codon position in that sequence. When you have a mutation in that codon, it often goes from an M to a V, which is a valine amino acid. So you have an amino acid substitution, which becomes clinically relevant because that reduces the effectiveness of many of our drugs that target reverse transcriptase. So how do we test for HIV drug resistance? The main method that we use is HIV RNA genotyping. And this is available for the 3 enzymes that are listed below. It's standard for most assays to check for reverse transcriptase and protease mutations. You sometimes have to ask separately for integrase drug resistance testing. I know that's how it is in the United States. I'm not sure how your assays are ordered in the Philippines, but if you have a patient where you're worried about integrase resistance, it's worth it when you send the test to the lab to specify that that's what you're worried about, to make sure that they do the testing for integrase specifically. And essentially the method is that they extract HIV RNA from the blood sample that you send, and then it goes through a similar process to what it would do in your cells. So they do reverse transcription, then they do PCR amplification of the DNA that's created, and then they sequence that out and they look for mutations that differ from the HIV wild type code. And this is important because drug resistance increases your risk of failure. So as we all know, the goal of treatment is to achieve and maintain viral suppression, defined as a viral load less than 50 copies per milliliter. And when you have drug resistance, your drugs are not as effective and your risk of treatment failure is higher. And in that situation where you're concerned about treatment failure, what you want to do is obtain a viral load. Per the Philippines guidelines, if your viral load is greater than 1,000 copies, that's when you should be worried about HIV resistance. And if it's available to you, this should prompt getting HIV resistance testing and switching to a second line ART regimen. Ideally, ART regimens contain at least 2, preferably 3 active agents. And knowing whether or not you have 2 fully active agents often depends on getting resistance testing. This is a resource that I want to introduce that is really helpful when you are interpreting HIV genotype. The Stanford HIV Drug Resistance Database is a free and publicly available website. It has a lot of information about HIV mutations, and it also helps with genotype interpretation. It has overviews of how to interpret different mutations. And there's an interactive program where you basically just plug in the mutations from your patient's genotype, and it will give you an interpretation. There's both a qualitative interpretation where they will tell you whether or not it's resistant or susceptible, and then there's a mutation score. And we'll go through this in detail in a future slide because we're going to use this program to analyze this particular patient. This is what the input looks like. So it may be a little small, but I think we'll share these slides. On the bottom left-hand corner here, I have the web link for you. And where it says HIV DB program circled, that is where you can access the interactive program that allows you to just enter your own patient's mutations, and it will spit out some results for you. I'm going to briefly walk through some common NRTI mutations, in particular the ones that are relevant for this case. So the first one we'll talk about is the M184I or V. I talked about this in a previous slide. Our patient had the I, but the V is probably something you'll see a little more commonly. And then the K65R is another common NRTI mutation that our patient had. Thymidine analog mutations, commonly known as TAMs, are a group of mutations that affect NRTIs. This patient did not have any TAMs, so we won't talk about TAMs in this particular case, but we can talk about it at a future session because you probably have patients where this is relevant. So, okay. So the next, I have one additional question before we talk about the M184I and V mutation. So I'll read it out and then we'll have the poll populated on the screen. Which of the following is not an effect of an M184I or V mutation? A is high-level resistance to lamivudine and emtricitabine. B is low-level resistance to abacavir. C is high-level resistance to zidovudine. D is, sorry, I can't see my own screen here. D is enhanced susceptibility to tenofovir. And E is reduced viral fitness. So which of these is not an effect of this mutation? Can we pull up the poll? And we'll do 30 seconds here. Okay. Give it a couple more seconds. I'm going to end the poll in 5 seconds. All right, let's share it. So we have a good spread of responses. Basically, we have all the answers got a decent percentage of responses. So this is a tough question. And let's see, the answer is enhanced susceptibility to zidovudine occurs. So rather than having resistance to zidovudine as part of this mutation, you actually have increased susceptibility. This is the signature mutation seen in patients who receive either lamivudine or emtricitabine. So in patients who are on lamivudine who perhaps do not have great adherence, this is something that we worry about happening early on. It causes high-level resistance to lamivudine and emtricitabine, low-level resistance to abacavir. It really affects most of our NRTIs that we regularly use. But interestingly, it actually increases susceptibility to zidovudine and tenofovir. So it sort of has an unintentional benefit. The other thing that it does is it reduces viral fitness, which really means that the virus is not as good at replicating as the wild type form. And so that also has an unintentional sort of benefit for us. One thing to know is that the M184I mutation often precedes the M184V. So it's sort of a stepwise pattern, but they have similar effects. And the M184I mutation has a greater impact on the viral fitness. Moving on to the K65R, this is another NRTI mutation that commonly occurs in patients who are on a non-suppressive regimen. So perhaps patients that were on regimens that only included NRTIs and didn't have a partner drug. Usually if patients have TAMs, which again, we didn't talk about today, but a different type of NRTI mutation, they don't also have the K65R, they don't come hand in hand. In contrast, we very regularly see the M184I or V plus the K65R. And this results in high-level resistance to tenofovir. It also affects abacavir, lamivudine, and emtricitabine, and it increases susceptibility as well to the zidovudine. So like I said, we often see these together, and this is just sort of a summary of the impact of the mutations when you see both of them in the same patient. On this, this figure on the right-hand side, in the middle is sort of wild type HIV, and then that like normally all of the NRTIs would be in the middle. They would all be susceptible. And then when you have these mutations, a lot of the NRTIs become, we develop resistance to the NRTI. So they move towards the left-hand side of this figure. In contrast, zidovudine is the only one where we have enhanced susceptibility. And so that moves towards the right on this figure. So that's really the only NRTI of this whole long list where it would still have a fair amount of efficacy. Now we're going to move on to NNRTI resistance. So a thing to know about NNRTIs as a class is they have a lower genetic barrier to resistance compared to PIs and INSTIs or other types of partner drugs. And resistance develops fairly rapidly in the presence of viremia. So in a patient who's not taking their HIV drugs regularly, or if they already have some resistance to the other agents in the regimen, you want to worry about NNRTI resistance developing rapidly. And if your patient has experience with multiple NNRTIs, it's important to know that cross-resistance is common, especially with the older generation agents, and those are efavirenz and nevirapine, which are still commonly used in a lot of scenarios. Speaking specifically about efavirenz, because our patient was on it, the K103N is the signature mutation, and it confers high-level resistance to both efavirenz and nevirapine. It does not affect later generation NNRTIs, including rilpivirine, if that's something that you have available to you. It is the most commonly transmitted resistance mutation. So some patients get this mutation at the time of infection, and it has nothing to do with their adherence history. Some other mutations to know about that are relevant for efavirenz are the Y188L and the G190S or A, because those also cause high-level resistance. And then if you have prolonged virologic failure and you continue to take an efavirenz-based regimen, additional mutations may accumulate, and they will confer broad class resistance to the other NNRTIs that are available when you combine all those mutations together. I've listed a few of those here, mainly relevant because our patient had some of these as well. So going back to our case, again, here is a summary of the case. We got to about the middle of the table here. The patient was switched based on his regimen to lamivudine, zidovudine, lopinavir, ritonavir, which was double dose because of his TB treatment. So another poll question here. We talked about these mutations. He's switched from his original regimen. Is this an appropriate regimen that he's now on, which is listed at the top? No, because none of the agents are fully active. Yes, because the lopinavir ritonavir is fully active. Yes, because there are two active agents, at least two active agents. And for Answer C, the two active agents are lopinavir, ritonavir plus zidovudine, versus for answer D, it's lopinavir, ritonavir plus the lamivudine as the active agents. And then E is, I'm not sure, I'd like more teaching on the topic. So if we could pull up the poll. I'm not seeing, do we have the poll up?
Vicky, kindly share the poll questions.
Oops, sorry about that.
Vicky, can you try showing the
Yes po,
poll
yes.
question? There.
All right, we'll do 5 more seconds. All right. Great. So we got mainly C's and E's, which is perfect. So C is the correct answer, and E is a totally appropriate answer as well. So going back to the Stanford HIV resistance database, we plugged in the mutations from this patient. And so this is sort of the result page that you'll see when you use this database. I've numbered it 1 and 2. So the top here, 1, this is where they just show you the clinically relevant or clinically significant mutations, which we've walked through already. And then part 2 here on the bottom, they look at the impact of each mutation and they assess the overall impact for each drug in that ART class. So for the NRTIs on the left-hand side of the screen, what you can see here is that the zidovudine is susceptible, which is what we would expect, right? It's actually probably more susceptible because of these mutations. In contrast, the combination of those 2 NRTIs makes the rest of your NRTIs, sorry, the combination of those 2 mutations make the rest of your NRTIs resistant. So tenofovir retains a little bit of activity, but the abacavir, emtricitabine, and lamivudine, they are no longer going to be effective for you. They will not really have any activity. And then if you look on the right-hand side, this combination of NNRTI mutations renders the efavirenz ineffective as well. The Stanford database also gives some qualitative discussion about each of the mutations, essentially the things that I walked through on my slide. So that's up here on the top. And then there are these drug mutation scores on the bottom. Using 60 as a cutoff is what they recommend. So that essentially means there's full resistance. And then negative values are enhanced susceptibility. So if you look at AZT here, you can see there's a negative value because you have enhanced susceptibility. Whereas if you look at abacavir, emtricitabine, and lamivudine, they're super high. So 60, 90, 90, those are fully resistant, and then the tenofovir is 40, so some residual activity, but not full activity. All right, so we're almost done here. Moving on to talking more about the management here. This is just to summarize what we've been talking about so far. So the first line regimen is not an appropriate regimen anymore because there's intermediate or high level resistance to each component of that regimen. In contrast, the second line regimen to which he was switched is an appropriate regimen now because the lopinavir, ritonavir, and the zidovudine are fully active. And then you're still giving that lamivudine, which actually maintains the M184I, which is a good thing in this case, because like we talked about, there are some unintentional benefits for us as the patients with the M184I or V, the increased AZT activity and the reduced viral fitness, so less viral replication. So this is a take-home slide, take-home point slide. I'm gonna not go through all of this because I think these will be shared. It just goes through the things we've discussed on previous slides. And open it up to questions now with the remaining time that we have for the case. Feel free to unmute yourself and ask your question verbally or put it in the chat. I'll try to pull up these questions here.
Yeah, so thank you, Emma. We have some questions in the chat box and actually John answered some of them, but I think it's important that we stress it for these answers, no, so that our participants will also appreciate
maybe
comments.
I don't know if John has additional comments that he wants to make at this juncture. Thank you for answering some of these questions in the chat. I couldn't see them while I was talking. So I don't know, John, do you have other thoughts you want to share?
No problem. Emma, thanks. That was extremely clearly explained. I just wanted to add that both of us are really happy to be here, and we are really interested in trying to tailor this to the group's needs. So this is really sort of an introductory session to introduce, we think, some important topics, and then really get feedback from you all about what you need to help take care of your patients. I think I will highlight maybe just the one or two questions from the chat. There were some comments about how genotypes are reported in the US, and I can't speak to what is seen in the Philippines drug report. We would get information on HIV subtype, which clinically we don't do too much with usually, but is of interest sort of from an epidemiologic standpoint. And then typically there's both a list of drug resistance associated mutations provided, and along with an interpretation by the lab of what the implications are for certain medications. And then additionally, there's a list of other medications or other mutations that are recognized, but not necessarily associated with drug resistance. So it is nice to have all of that data provided. And it sounds like there may be some variability in terms of what clinicians are seeing from testing in the Philippines. And another question that came up from Dr. Roman was a very challenging question about how to manage protease inhibitors in the context of TB therapy, which I think we probably need a separate session to talk about management of TB in the context of HIV. I tried to suggest just a couple of things. In the US, of course, we have things easier because we have more tools available. Rifabutin certainly is easier because of fewer drug interactions, or at least less profound drug interactions, and that gives us more options. We don't really use lopinavir or ritonavir anymore, and we really don't do double dosing or super boosting of PIs because of tolerability concerns. If we needed to treat a TB patient with HIV, or HIV positive patient with TB who needed to be on a protease inhibitor, we would likely be using a rifabutin based approach. These days, many fewer of our HIV positive patients in the US need to be on a PI, and we are much more heavily relying upon integrase inhibitors. And so many of our TB patients with HIV will be on a dolutegravir-based HIV regimen. And I think we probably should maybe defer further detailed discussion to a separate session so we can do it justice. But those are just a few comments, clearly quite different in the US given the other tools that we have.
So thank you for that, John. So in the Philippines, there's a laboratory that just reports if there's high level resistance, low level resistance, susceptible to the ARV. So they don't actually show the mutations. There's another laboratory that also includes in the results the mutations. So I agree that I think it's very important that the mutation should be included in the results. So
Absolutely.
For TB treatment, you mentioned that I think it should be a separate session. And yes, so we can actually have a separate session for TB, HIV, and treatment, with antiretroviral treatment, antiretrovirals during TB treatment. Okay. So, and I think it was mentioned by our participants that we really have very limited antiretroviral drugs in the country. And we really try to, manage patients using these very limited choices of antiretroviral drugs. Okay, so there's actually one more question for Emma and John, and this is from Dr. Roman. We are unable to test for dolutegravir resistance. Is it safe to use TLD among patients with LAMI resistance, tenofovir intermediate or susceptible? Or should we add lopinavir ritonavir if the genotyping shows susceptibility to lopinavir ritonavir? So now it becomes TLD-LPVR. And I think this will be part of the next discussion of Emma. Yeah, so we can answer this question in the subsequent slides of Emma. Correct, Emma? This will be.
I have some more slides that I can share. That
Okay.
It's more about time. If you have more time, I have 2 more slides.
So we have limited time because we still have the QI part of this session. So maybe we can proceed with the discussion. Thank you.
So this patient did have one additional shift because of zidovudine stockout. So they were shifted from their second-line regimen to lamivudine, tenofovir, dolutegravir, plus the lopinavir ritonavir. And so, it sounds like other people are already thinking about this question, but is this an appropriate regimen? And the options are no, there are not 2 fully active agents. Yes, because the lopinavir ritonavir is fully active. Yes, because there are at least 2 active agents here. Sorry, I can't actually close all of these things so I can see my own slides. Okay. C is lopinavir, ritonavir, dolutegravir. D is lopinavir, ritonavir plus tenofovir. And then E is, again, I'm not sure, I'd like more teaching on the topic. I'll skip the poll in the interest of time. You can think to yourself what your answer is.
Okay.
And just get here. So, I think in response to the question in the chat, in this situation, the dolutegravir and the lopinavir ritonavir are fully active, and the TDF is partially active. And in part, that's because you have the lamivudine on board maintaining the M184I, which reduces the viral fitness and gives some increased susceptibility back to the tenofovir. But I mean, I think especially in a patient where you're concerned about resistance and poor adherence, you want to make sure you have 2 fully active agents that are on board, and the tenofovir is not a fully active agent. So I think that the smartest thing to do in this situation, if it's available to you, is to continue the lopinavir ritonavir as well, and not just have the 3-drug combination. And then the benefit here is that, dolutegravir has a very high barrier to resistance, and it's rare to see any transmitted drug resistance for this INSTI, this integrase inhibitor. And this is a pretty robust regimen that you would be putting the patient on. So this would be the preferred thing to do because the patient has had issues with adherence in the past. I'm hoping that answers the question. I don't know, John or Janice, if you have additional comments about that.
So maybe to put this issue into the local context, in the Philippines, if a patient fails first-line treatment, the next regimen will be dolutegravir. So, and not necessarily dolutegravir plus lopinavir ritonavir. I think this patient was placed on both ARVs because there was genotyping result. So that's why Dr. Roman asked if it's okay to just put the patient on dolutegravir without adding lopinavir ritonavir.
Yeah, I mean, I guess so. If you did not include the PI, if you didn't continue the lopinavir ritonavir, you would still have more than one fully active drug, but you would not have two. And so I think it is risky, especially if you have a patient who is not fully adherent. You know, the other thing here is in the background, we've talked about this patient's TB. At this point in the case, the TB is considered treated, and so they're no longer on rifampin or you know, any sort of rifamycin. But if you had a situation where you needed like double dose the BID dolutegravir, excuse me, and you had worries about the patient's adherence, that would make me very concerned personally about, you know, making sure you're getting sufficient drug levels. And I wouldn't want to do anything that would risk developing integrase resistance, like if you're only taking, you know, 1 or 1.5 active medications. But I recognize the limitations. If you don't have this resistance data, that's not, we sort of have the, you know, this is in retrospect, we're able to look at the resistance data and as Janice said, guide the shift, but that's not always available.
Yes. So thank you very much, Emma, and thank you very much, John, and also to our participants who are sending their questions in the chat box. We have to end this part of the session because we still have the QI lecture. We'll have a 5-minute break, but for our participants, you can continue putting on your questions in the chat box. And I hope Emma and John can continue answering our participants' questions through the chat box as well. So we'll have a 5-minute break, and then we will, maybe 4 minutes already, and then we will come back for the QI lecture. Thank you very much.
Thank you.
Thank you, Emma. And thank you, John.